So, welcome everyone, and welcome to Let's Talk Menopause, Menopause Talks. Let's Talk Menopause is a national nonprofit changing the conversation on menopause to ensure women get the information they need and the healthcare they deserve in midlife and beyond. I'm Alessandra Henderson. I'm the Senior Program Advisor to Let's Talk Menopause, and I'm thrilled to be working with this incredible team on our educational program. These talks are central to our education efforts to ensure that women receive evidence-based menopause information, and we have over 30 talks on our site. So if you like what you hear today, please join us. Today, we are so thrilled and honored to be joined by double board certified, fellowship trained orthopedic surgeon, Dr. Vonda Wright, for an in-depth discussion on what happens to our joints and bones as we age, managing joint pain and frozen shoulder, and how to, very importantly, how to build strength in menopause and beyond. We are going to dive into the talk, but first, a few housekeeping items to make sure we're all on the same page. A reminder that all menopause talks are intended for informational purposes only. They're not as a substitute for professional medical advice, diagnosis, or treatment. We have disabled the chat, but we will be providing you with links throughout the talk, so please go check them out, an incredible wealth of resources. If you do have questions, we have an app called Slido. You should see a prompt on the screen inviting you to participate. A note, this is our most popular talk ever. We were just talking before this. We are so excited. I know we need to dive in, but this is our most popular talk ever. Many of you have submitted questions, whether it's on Instagram, email, in advance. We are going to do our best to answer those questions, but there's so much to cover in a short amount of time. And we are planning to putting out more content around this topic in the future. And we'll also talk about Dr. Wright's new book. So I'm sure there's a wealth of information there, but please ask your questions, but be patient with us because this is a popular topic. There's going to be a brief survey at the end. We'll send out a recording of the event, and a huge thanks to Bayer for making this talk happen in terms of our sponsoring these talks to make sure that we're connecting with the best experts. Okay, today we are joined by Dr. Vonda Wright, bearing the lead here, a double board certified orthopedic surgeon and internationally recognized authority on human performance, longevity, and women's health. Dr. Wright is the founding director of the Performance and Research Initiative for Masters Athletes, PRIMA. She served as a physician for athletes at the University of Pittsburgh, Georgia State, the Pittsburgh and Atlanta Ballet, World Rugby, and the PGA. She's a highly sought after media expert who's been featured on the Jay Shetty and Mel Robbins podcasts, the Today Show, the New York Times, USA Today. It's a very, very long list. She has authored 5 books, including Fitness After 40, Guide to Thrive, and her newest book, Unbreakable, which comes out in August. And I'm going to plug this at the beginning. You can pre-order it now. We'll drop the link in now. If you do anything before the end of the talk, please do pre-order that. But we're thrilled to be getting a sneak peek of that through her work today. Maybe just so we can dive right in, if you could perhaps start by introducing yourself, your unique approach to women's healthcare. I know we talk a lot about movement as medicine, health span versus lifespan. Maybe you could just talk about kind of your philosophy of care when it comes to women's health and aging bodies.
Sure. You know what? I have been critically interested in the health of the whole woman. I wish I could say my whole career, although my first career in medicine was as a cancer nurse in the 1990s when we weren't quite as good as we are now. And we still have a lot to do, but not quite as good as we are now curing cancer in women. And so at a very young age, I learned the suffering of women. I learned the value of women. I learned how women dealt with both healing and diagnosis. And so at 23, 24 years old, that left an indelible mark on how I have always approached my practice. And then I went into orthopedics, and that's another whole long story. But the mantra for my entire career is that I'm going to change the way we age in this country, because I have never believed that aging is an inevitable decline from the vitality of youth down a slippery slope to frailty. And yet many people, including many women I talk to every day, just feel like decline is inevitable, that the 2/3 of nursing homes that are filled with women is just the way it has to be. And I don't believe that, because in my own life, I feel like I have gone from the misery of menopause, and I'm happy to tell you my story, into truly feeling like I have come close to mastering this time of life. And I am out trying to share that every step of the way, whether it's frozen shoulder or the musculoskeletal syndrome of menopause, or teaching women the fundamentals of how to build an unbreakable future. Because I do not see us, and you'll hear this again and again as I'm talking today, I do not believe that we are the victims of the passage of time. I mean, women have already won the longevity battle. We live 6 to 7 years longer than men in general, but we live in worse health. And that's because we age differently. And part of what we're going to be talking about today is that. So I feel like the more you know, the more powerful you are. So I'm glad everyone is here today. And frankly, I'm a little competitive. So good for us today that we're the highest registering webinar. But what it shows, if I take my ego out of the way, what it shows is the need is so great to understand our musculoskeletal health. And I think this is just a good example that we began last July when we published the musculoskeletal syndrome of menopause paper, naming the things we're going to talk about today. And do you know that paper has been downloaded almost 400,000 times. In
Wow.
the world, yes, where most research, the best papers are downloaded 10,000 times, and 50% of all papers are never read by anybody except the authors. And again, I could say, oh, because Vonda Wright writes the best papers. No, that is because the need is so great.
Mhm.
So
Yeah.
that is a long introduction to kind of the way I approach things. And I got to tell you for sure, the reason I believe people listen to me as strangers on the internet who come to feel like they know me and my approach.
Yeah, well, it's very powerful, and I appreciate framing that at the top of this. And what we'll try to do, we'll go through, right? Some of the stats are it can be tough to hear, right? That women, experience rheumatoid arthritis 2 to 4 times as likely as men, or we lose 20% of our bone loss in the first 4 to 5 years of menopause. Like, there's a lot of very
Yeah.
negative stats, but what I appreciate about you and your philosophy and approach is the proactiveness, and that there's always something to be done and that we can take control. And so that's what I'm excited to dive in with you today. So with that, I'm hoping to kind of go through a little bit of that, the physiology of it and what's happening with our bodies before moving quickly into that, what actions can we take? So with that, perhaps you can start with, what does cause joint pain in menopause? What's happening during this transition?
Right. So the musculoskeletal syndrome of menopause is a combination of multiple symptoms that you may have tried to go to your doctor about. And when you go in and say things like, my whole body hurts, and I don't know what's happening, but I can't move my
Okay.
arm. Yeah, I did nothing, but my arm doesn't move. I can't hook my bra. Coupled with the stats about the muscle, the bone, the loss of stem cell integrity, the explosion of low back pain and arthritis that happens around age 50, and a variety of other musculoskeletal things, any discerning person is going to think, OMG, is there a common root cause? Well, it's not just the fact that on one birthday you're 49 and the very next day you're 50. It's not like a light bulb goes off. But what does go off, and your audience knows this, is our supply of estrogen.
Mhm.
And just like the work that many researchers have found, oh my goodness, there's estrogen receptors on the brain. The heart loves estrogen. Blood vessels love estrogen. Bone loves estrogen. There are estrogen alpha and beta receptors, or if you're thinking about it out there in a visual learner, I view them as little baskets sitting on the surface of a cell. Estrogen sits in those baskets and causes all the beautiful downstream things that happen in your musculoskeletal tissue. So all musculoskeletal tissue, whether it's muscle, bone, tendon, ligament, fat, the discs in your back, muscle stem cells all come from a common origin. They're cousins. They speak the same language, maybe different accents, but the same language. And so when estrogen is no longer sitting in these baskets, there's going to be a reaction. One of the things that estrogen is a profound influencer of is total body inflammation. How that affects the musculoskeletal system are in the two most common things. One, total body pain, which is called arthralgia. And number two, frozen shoulder, because frozen shoulder is due to inflammation. So men with diabetes and high blood sugars get frozen shoulder. Women with diabetes and high blood sugar get frozen shoulder, but so do totally healthy midlife women who have lost their estrogen. The shoulder is extremely sensitive, becomes inflamed, and stops moving. So the key takeaway of that long tirade is the science is every musculoskeletal tissue has estrogen receptors, which are then empty, and the health of that tissue declines unless we do something about it.
Great. And we are going to talk about, there are questions of, just so you know, there are questions of what is the optimal estrogen level? Do you take menopause hormone therapy, or MHT as we call it? There's HRT, hormone therapy. We do call it menopause hormone therapy at Let's Talk Menopause. We're going to get into how we can do some of those treatments. But maybe, you know, we got some questions from both online, but also from our community of, how can I tell if what's the difference between frozen shoulder versus torn tendon versus rotator cuff? You know, the list goes on. And how do you have those conversations with your doctor to identify what's what?
Rotator or shoulder pain in general does not shoot down your arm. Let's say what it's not, because people, unless you're into anatomy, why would an accountant know the anatomy of the shoulder, right? Shoulder pain is here. This is it right here, like you're wearing a shoulder pad. It is not shooting down your arm. It is not in the back over the scapula. It is here. So one differentiator is it hurts, but it moves. Maybe it's a rotator cuff or an injury. It hurts and it will not move, literally will not move. Frozen shoulder. And then you think to yourself, did I actually hurt it? Did I get up in the middle of the night and hit it on the door? No. Most women come to me and say, I did nothing. I didn't hurt it. One day out of the blue, I woke up, my shoulder was painful. And I said, you know what? I'm going to just bear it out. It'll probably go away. And within 1 week, right, it won't move. And you can't do the Vonda Wright hook your bra test, right? It's a silly way to say you have no internal rotation, which is this motion I'm doing now. So those are some ways to tell, is this a rotator cuff, meaning it hurts, but it moves, or is it hurting, will not move? Now, not every shoulder pain is a frozen shoulder. There are some rotator cuffs, but 40% of the time you'll go to your doctor. They will work you up appropriately, maybe x-rays, maybe an MRI if they believe it could be a rotator cuff, and nothing is found. You're sent.
That was a very common complaint.
Yes.
Not complaint, but a statement, because it's not a complaint.
Nothing is found. And then you're sent packing like, I don't know what's wrong with you. Nothing's wrong with you. Maybe you're just getting old. Listen, I have queried the women who listen to me on Instagram, and the things that are said to them by everybody and orthopedic surgeons, it's frightening, and it makes me sad for my colleagues who will just dismiss 51% of the population. So if you have a rotator cuff tear on MRI and your shoulder doesn't move, the treatment is the same for if you have shoulder pain and no motion out of nowhere, and that is early motion, anti-inflammation. I'm not a big steroid person, but plus or minus steroids.
Okay. Okay, so first of all, always advocating for yourself, but two,
Right.
and some women said, I will say, I've been advocating to get an MRI, but I'm not, being heard at my doctor, but at least
You
going
don't
through.
need an MRI. And if your shoulder will not move, you don't need an MRI until your shoulder moves again.
Okay,
Because number one, you might not be able to get into the MRI machine. Good MRIs of the shoulder are done like this.
yeah, okay, which is,
So yeah,
yeah, sounds nearly impossible. And I don't think that the bra, the bra, can you hook your bra test is silly. It's actually probably the
it's a
best daily
real thing.
litmus test. Yes, the best daily litmus test to understand that.
Real.
Well, and again, we're going to get into how do you navigate it and call it treat or, help correct that. But, oftentimes we get questions of, I'm in perimenopause or I'm about to enter. If we could talk about kind of the frozen shoulder / joint pain, which I know they're not completely linked, but if you are in perimenopause who aren't experiencing it yet, what can you do to potentially prevent or delay these joint issues? And then we'll dive deeper, obviously, into what happens when you're experiencing that.
I think perimenopause comes in all flavors, right? It comes at the very beginning when you're just starting to see some change in your estrogen to right before you have your last period, perimenopause. So it's a wide range of things, but I think it is the perfect time to start developing. Actually, I think the perfect time to start developing these standards and habits is in the critical decade, which I call 35 to 45. We're still having our periods, we still have estrogen, we just are high risk pregnancy, which means according to OBs, we're getting old. Me having saying this because I had a child at 40 and was called geriatric, which I always like to
Yeah.
tease them about. But
Yeah.
that is the perfect time to get things in order. If we're not yet in order, or we start having these increased inflammatory signs, it's still a time to let's look at our diet. Are we full of sugar? What are the standards of nutrition we're holding? Because if we can get ahead of this, let's just stick with inflammation. If we can get ahead of a highly inflaming diet as our estrogen is going chaotically down, we're going to be better when we arrive on our day of menopause. So in perimenopause, I wouldn't start right away thinking about hormones, although I might, and I'll tell you my opinion on that. But definitely, what do I need to know? What do I need to get in front of? How do I maintain my range of motion if it feels a little stiff? That kind of preventative type thing.
Okay.
Before you get stuck.
Okay. And when we talk about, and there's some questions that are coming through, and so I'm glancing, it's, every single, there's so many. But the question is, how do you know if it's soreness or when to get things checked out? Do you have a litmus test there of when to go to the doctor?
If your arm is not moving, do not pass go, do not collect $200, go to physical therapy. In many states, you don't need a doctor's prescription to go to your first month or your first 12 visits of physical therapy. Because if you catch it early and don't wait for it to get better, you can continue moving. If you don't have that availability or you're so frozen stiff, it's excruciating painful, you may want to go to the doctor just to get a steroid injection to decrease the acute inflammation so that you can actually do the work in physical therapy.
Mhm.
Because the cure for this is mobility, getting it moving, anti-inflammation, which includes things like making your menopause hormone decision, diet, and things medically like
Yeah.
anti-inflammatories and PRP.
Okay. So let's move into that because there's so many things coming through. So, we can assume that many women on this call, and let's just focus maybe on frozen shoulder for now while we're on the topic. But expanding that, of course, so frozen shoulder into also just how our
Sure.
movement is medicine. What can we do to help treat and
Number one, know what it is. I think I call this time in life, this transition in life, the menolescence. Because it's bio, psycho, social, hormonal. During menopause, the best thing we can do for ourselves is become an expert at this time of life. Because think back at adolescence when we got our hormones, we didn't know what the heck was going on. Now today, young women are given all kinds of books to read and videos to watch. But when I was being raised, it was barely talked about. And I think that's kind of where menopause outside of this forum is, right? That many people are still not talking. So education is number one. Number two, if you particularly have total body pain or a shoulder that doesn't move, anti-inflame with diet, anti-inflame by continuing to move. Stiff joints are more painful joints. In the case of a frozen shoulder, I said it once, I'll tell you again, get into a physical therapist immediately. They all know what frozen shoulder is. They'll all move your arm in a way that you will not be brave enough to do on your own. Sometimes it takes someone moving it for you. If you can't tolerate it, then that's the time to seek medical care, either from a non-operative sports doctor or an orthopedic surgeon to get a shoulder injection so that you can tolerate the therapy, because under no circumstances should you stop moving this shoulder.
Okay. And so you mentioned diet. Can you just talk maybe a couple of things to either focus on or avoid?
Yeah, you know what? What's interesting is people will adopt almost anything I ask them to do, except eliminating simple sugar. It's like I'm taking away their firstborn, because our brains become addicted to the dopamine hit in our addiction centers of sugar. Again, the first thing to do is understand what you're eating. Any packaged food is likely to have grams of added sugar, even things that are healthy, air quote. You need to turn over the package and read how much sugar. We don't want more than about 50 grams of total sugar a day in our foods, but you won't know that until you look. For instance, here's an example. I eat this marvelous Greek yogurt that actually is palatable to me. Well, I turned it over and I noticed, because I wear a continuous glucose monitor because I love data, that it was raising my blood sugar. And I thought, why was that? Well, because you turn it over and it has 4 grams of added sugar. Well, that doesn't sound like a lot, but that's a tenth of what the total sugar that I want in a day. So you have to read the labels, number one. Number two, from a dietary, we must focus to get our carbs. We're allowed to eat carbs, especially if we're very active, as whole food fibrous carbs. So that means, I'm sorry, people, we are not going to make juice smoothies. We are not going to make berry juice smoothies. We are not going to drink juice because it's freshly squeezed and gorgeous, because that is a high glycemic way to spike our blood sugar. And you're not getting any fiber because you've already broken it down with the blender. So if you want fruit, eat the whole fruit and eat it for dessert. If we do this, I have personally done this because I love sugar, even though I don't eat it. If we do this within about 7 days, your taste buds will change and you won't crave it as much anymore. And I can physically feel when I have eaten too much sugar in a day, because I'm sore again. My body feels sore and my brain feels sluggish. So nutritionally, if we're going to do one thing, there's a lot of things nutritionally I like people to do. That is the one thing that's really going to help you with your pain.
Okay, that's very helpful. So diet, you mentioned exercise, and by that, physical therapy exercises, going to a PT, so an expert who's going to do things that you don't want to do. Are there other resources as people are continuing, right?
Well, I think this is a good time to state my philosophy, and it may help us with other questions in the future on menopause hormone treatment, or as I
was going to get to.
I tend to call this hormone optimization, right? Here's the deal. I believe that every woman is a sentient being with agency, meaning you're alive and you get to choose. You get to choose. But I want you to choose from facts, not fear. And I'm going to say things that are right now that are completely research based, But yet, I mean, I treat patients every day. I'm still a practicing doctor. I did surgery this morning. I know this is what's happening.
Wow. Yeah.
Women are still so profoundly terrified of the notion that if they consider estrogen replacement, that they're going to die of breast cancer at a higher rate than the general population. And I will continue to say in a very passionate way that there is no evidence that estrogen of any kind will increase your chances of dying of breast cancer. Now, do I still think that every woman gets a risk assessment? Yes, you get to choose. There is a lot of data that even women with genetic predispositions can be safely administered estrogen after a risk assessment. So we should not make these blanket statements, because here's the deal. Only 4% of women in this country right now have taken advantage of something your body has made your whole life that can decrease all-cause mortality by 30 to 40%, that will decrease your chance of getting a fracture. 1 in 2 women will have an osteoporotic fracture profoundly, that is known to prevent heart disease, is known to prevent decline in brains. Listen, you get to make the decision, but based on those research facts, not on some wives' tale in a grocery store tabloid about your best friend's grandmother's Aunt Minnie 12 generations ago. I just want women to be less controlled by bad data than we have been since 2012.
Yeah. I appreciate that and sharing. There are a lot of questions around MHT on
Yes, of
the
course there
treatment
are.
of both frozen shoulder, but also expanding, just joint pain and the musculoskeletal symptoms. So maybe
So
you can
when
talk
my
a little bit
women,
about that, the
yeah,
application.
when my women get this discussion with me, which they do when they come to see me, even as an orthopedic surgeon, um, and I hook them up with sources that they can get their own assessment, and they decide to go on MHT, sometimes within a week, they feel better,
Yeah.
often within a month. And if they don't, it's because they've been started on ultra low doses like 0.025, which is the lowest possible transdermal dose. And we just have to optimize their doses to the level their body needs. And so it is profound to watch this, and how thankful women are in their follow-up visits, because often they've suffered for years.
Mhm. I'm
And
going to double down on this. So one, thank you for both educating and championing.
Mhm.
But I want to kind of drill maybe a little bit further in here, because to your point, some women in a week feel better, right? It was that lack of estrogen that had been causing not just joint pain, but the cascading impacts of menopause that we hear about so frequently. Others, there's the titration of doses, right, and increasing. I'll also say there are some women who wrote in on our Instagram or around this topic who said, I've been on it for 5 or 6 months and I'm still experiencing either joint pains or frozen shoulder or some of these musculoskeletal. So maybe in those instances, yeah, it's not the panacea, right, of everything. So,
well, it's not one thing. I'm so glad you brought us back to here, because just making a decision in the positive, meaning to take MHT, is not the whole story,
mhm.
right? It is about, that is one item in a lifestyle, because the fact of the matter is, we're not the same as we were when we were 20, and nor would I want to be. There are the natural pathways of aging that are then just augmented by loss of estrogen. So estrogen is not the one and only. If we are still highly inflamed, eating terrible things, terrible is a judgment, but objectively unhealthy, ultra processed food, and treating this vessel like a garbage disposal, okay, that's something to work on. If we are unable to continue mobility, right, we're just getting stiffer and stiffer and stiffer. Stiff joints are painful joints, no matter what the cause is. We have to continually be moving our joints. If we are afraid of gaining too muscle and getting big, and therefore have not caught on to the messaging around women of all ages need to build and maintain muscle, that can cause a lot of increased pain in your hips, in your glutes, in your low back. So this is a multifactorial pathway. It is a lifestyle. It's not a diet. It's not an exercise program. It's a lifestyle. Does that make
Mhm.
sense?
Oh, it definitely does. It's health is it's interconnected. It's not, and historically, where we've treated one organ in the traditional healthcare system, when in fact we are a, system.
That's right.
It's
We're
a
a system.
functioning systems.
Yeah, we're an
Uh,
organism.
we do have questions, especially from women who are not able to take menopause hormone therapy, either through a range of, right, whether it's family history, breast cancer, whatever it might be. So, what do you recommend for women who are unable to take
Huh.
menopause hormone therapy, who want to?
Who want to but cannot, and I know how frustrating that is, and I know, and I want to recognize that often you feel left out of the conversation, like
Yeah.
nobody invited you to the party, and I certainly don't intend to do that, because here's the good news. Remember what I just said? I think the decision about MHT is critical. And if the decision has been made for you, it does not negate the entire lifestyle that's available to you. And I have many, many examples of women, particularly in their early mid 60s, who are far enough away from their menopause that A, they were never offered, B, um, the worst is past, so they're like, I'm not sure I want to start it now, who have still transformed their health with the things I've already talked about, with macro-based nutrition, with no added sugar, with learning to lift and building a significant quantity of lean muscle mass, of stop burning ourselves out on high intensity interval training every single day, but doing what I call 80-20, 80% of the time is in lower heart rate, aerobic, and then 20% of the time you churn it out as a high heart rate. As an orthopedic surgeon, that is a great way to maintain body composition, heart health without overusing your joints all the time. So the hopeful message is just because one thing is not available doesn't mean the rest aren't available. For instance, and I often get comments about uh, prescribing exercise, and there are people who literally cannot. Their life is confined to a wheelchair, or there are neurologic problems. Well, so let's say sprinting is never going to be available to them. Everything else remains available. I view it the same way. We
Mhm.
can't just stop. We have to look at the other available options and optimize those.
Yeah. Well, maybe could you just, because that 80-20 is a great rule. And I know, some women they're used to that, the high intensity training or whatever we were doing in our 20s and 30s,
Yeah.
might need to shift. And so could you maybe drill a layer deeper on what does 80%, what does that look like? Is that a walk? Is that a fast, arm walk with weighted vests? Weighted vests are so popular right now. Like, what does it potentially look at, like, to
Yeah.
do that 80-20?
Well, number one, it means getting off the couch. So anything will work. I do not want people to have another barrier or a gate to being mobile. You just do what you've been doing since you were 1 year old, which is walking around.
Mhm.
So we've all got that skill. So when I say the 80-20, it means that what I see, my office is in a performance a gym, if you will. It's like a high performance place. And what I see is 7 days a week, people out doing high intensity circuits where they don't spend a lot of time doing anything, and their heart rate is not maximum and it's not low. It's just in this gray zone. And whatever, that's fine. But if we're trying to optimize, data has shown that our basic skill is brisk walking. So 80% of the time, or 3 hours a week, broken up in no less than 45 minute times, we're brisk walking. And so if we want to get really technical about zone 2 base training, which I do in my book Unbreakable, that comes from the research of our lab is based on the research of done on the Tour de France, where pro
Mm.
athletes tend to train at the two ends, right? They base train, they get their basic cardio down, and then they really push it. And so that's what I'm asking you to do. Low heart rate, around 120, 130 heart rate, 45 minutes, 3 hours a week. Twice a week, we're going to push harder. Now, I realize that if you haven't sprinted since you were 17, that the thought of this sounds crazy. If we're only thinking about it on a track, it doesn't have to be any way. So alpine ski thing where you pull it down, bike, rowing, or sprinting. I tend to do my sprinting on a track for 30 seconds, getting our heart rate up as high as it will go. So there I am at the end of my zone 2 workout. I am pumping it up to 11 on the treadmill, and I am trying to sprint so hard I don't fall off the back, but only for 30 seconds. And then you turn it all the way down, you walk it off, your heart rate recovers over the next 2 to 3 minutes, and you repeat 4 times. In my experience and the people I work with, it is the combination of the sprinting and the lifting heavy that recomposes our body by helping us lose the unwanted fat and replacing it with muscle. That's what I mean by 80-20.
Okay, that's helpful. And that's in realistic terms, right? Of we don't all have access to the gym. We're so busy, we're running around. But if you can replace one of those coffee runs to a walk instead of a drive,
Oh, yeah,
these small things add up.
absolutely.
So appreciate that. What about, I'm going through the list here because there's so much to cover. What about, there are always questions around supplements, and what does that look like in terms of supplementing your routine, vitamins, supplements,
Yeah,
additional over the counter.
yeah.
What are your recommendations here?
So, listen, it's possible to take 6 gallons of supplements and eat so much cellulose plastic every day. The basic stack that I myself do and I introduce people to doesn't include that many things. Not because some of the other things aren't useful. It's just that let's get the basics first. Because that's how I start. Can I just deviate for 2 seconds? When you guys are thinking about this, I have a lot of people come to me who are in a current state of fine. I feel fine. How are you? I'm fine. But they come to me wanting to do all kinds of really advanced longevity. Let's try all the things you've ever read on the internet while our health itself is not optimized. So when I answer this question for you, I'm answering let's optimize the things that need to be optimized first, and then we can add on and layer on all the way up to the very esoteric, proven only in rats things. So for my people, we look at vitamin D. What is your vitamin D level? Everybody's is low, so we supplement with vitamin D. We take that with K2 to help absorption. I usually like people to use magnesium for bone health. But listen, we all know midlife sleep is disrupted and that magnesium can be a wonderful augment. So either magnesium L-threonate or magnesium glycinate.
Mhm.
Those are the two forms that I use most regularly, not only because of their help with bones, the magnesium portion, but because they calm the brain and help sleep and decrease anxiety. So those two. If you're choosing, do not choose magnesium citrate unless you would like to have diarrhea, because that is what we use in the
All the
hospital.
symptoms that women get in menopause,
I
we need to
know.
layer one more on.
Yes. So don't choose that unless that's your goal, because in the hospital, that's what we use.
Yeah.
So just word to the wise.
Yeah.
So those three things, then I think a good omega-3 for anti-inflammation is worth it
Okay.
if you find one that doesn't, taste like fish in your mouth all day. Um, then many of us try really, really hard, but have gaps in our micronutrients. So I never think a good multivitamin is a bad thing. And
Mhm.
I wouldn't buy a really expensive one. I would just buy a good solid brand that's multi-lab tested, because your body will pee out what you don't need, right?
Mm.
So I'd hate for you to spend thousands of dollars on something you're going to pee out anyway. And then I personally, and for the people who are in my longevity programs, we use something called Fisetin, which is an herb from berries that is really good for senescent cells, which is a cell that can really cause a lot of disease in our body with aging, and Fisetin helps with that. Um, what else? I'm thinking down the list. I don't have people take a lot of things. Oh,
I was going to ask. Oh, go ahead.
people always ask me about, should I take a calcium supplement?
I was going to say calcium and collagen are the two,
Oh,
and,
let's cover
and
those.
creatine.
Oh,
So
creatine.
three
Let's
big,
cover those
three
three.
C's.
Yeah.
Yeah.
Uh, calcium, I want you to get in your food. It's not that hard to get 400 milligrams of calcium in your food. A yogurt or salmon or prunes or figs. So I would try really hard to get it from whole foods before you start taking a calcium supplement. So that's number one. Number two, creatine. I became aware of creatine in 1992 when I was in a sports doctor capacity working with the U.S. Olympic wrestling team, and we were loading very high doses. We had to cycle it on and off. That is not how we use it today. We use it in very low doses, 5 to 10 grams a day, to augment muscle growth. But there are numerous studies, one just came out, that indicate that it may also have profound brain effects, even in people with Alzheimer's. So it's one of the most studied. Creatine monohydrate is the most common form. It can cause a little bit of GI upset, so I always take mine with food so I don't get nauseated. But yes, if you're trying to build muscle, creatine's great. It will not, unless you're in high doses, in my experience, make you puffy, which is something people ask me all the time.
Interesting.
And then finally, collagen. Well, I wish that there were profound data on collagen. The
Mm.
only data that can be really defended is a few forms of collagen for bone. The data for skin is plus minus.
Mm.
Data for ligament and tendon plus minus. But here's why. You have to understand the digestive cycle. Everything you eat, everything, is broken down by the acid in your gut into its smallest form. So collagen, a protein, is going to be broken down into amino acids. You then cannot direct where it goes in your body. So if you take a collagen supplement that says it's going to be a miracle for your face, collagen, can you, unless we label this collagen, this is what we would do in the laboratory. To follow it, we would label it with some kind of green dye that fluoresces in your body and in the mouse, where we can track it, or we would track it with radioisotopes. We don't do that in humans, right? So we cannot prove that it's going where you want it to go. So I'm sorry to say that I suggest collagen plus minus. In bone, I'm going to tell you for sure, I am so desperate to get people to build better bone. Even if it has a remote chance and some data, it's not going to hurt you. So let's try it, right?
Yeah. I was just going to say, we haven't talked yet about, and there's still some things we can do. I want to talk about massage therapy and certain things, any of the just kind of additional how we build strength in menopause and beyond. But while we're on the topic of bone health, this is such a big one. Right? We know, there were questions that came pouring in of, I have a family history of osteopenia or osteoporosis. Am I doomed? What can I do? So can you talk
Yeah.
first of all, can you define osteopenia and osteoporosis?
Yeah.
And then maybe get into some of the things to look out for or actions to take around that? Your recommendations there.
Absolutely. Bone health is a lifetime concern. We build our most bone and we obtain our peak bone mass between about 15 and 25.
Wow.
So if we are not eating as a child, if we are such an exerciser that we can't take in enough calories, if you're like me, I was a ballet dancer, I wouldn't have periods for 6 to 9 months. Nobody told me that was a bad thing. I just thought it was great because I didn't have to mess with it. You are not building bone to peak bone density, or maybe you're so sedentary because we're a digital world, right? That is going to carry on into your adulthood. And then in our 30s, or whenever we decide, we lose a significant amount of bone density during our pregnancies and our breastfeeding. Now, our bodies are designed to replace that if we eat enough food. If while we're breastfeeding and our baby is taking 500 milligrams a day, we are eating that much calcium back. But the osteoporosis of pregnancy and breastfeeding are real and very limitedly known. So then we get into midlife, and I am not kidding you. I get DEXA scans on, or REM scans, which is ultrasound looking at bone quality, on every woman. And
there was a question about how frequency and when to get DEXA scans.
I would get my baseline at 40, just like your mammogram. Get your baseline so you know where you are.
Yeah.
Because if your mother is shrinking, if you are shrinking, if you've had a fracture after age 20, if you had an illness such as asthma where you had to take a lot of steroids in your life, if you have an autoimmune disease, if you smoke or vape or have a high alcohol consumption more than about
because the bubble of who is included here gets,
it's almost everybody.
Yeah.
Will not lay down. You're at risk for low bone density. Low bone density on a DEXA scan is defined as a score of -1 or below. So a DEXA scan is read on a bell curve like a test in school, where 0 is the bone density of a healthy 30-year-old woman. Any positive number on the T-score is good. Negative down to -1, that is the beginning of osteopenia. It is the time to get it together with all the lifestyle interventions, the MHT decision to build better bone, because you still can. If you are -2.5 or below, that is osteoporosis. 1 in 2 women will have an osteoporotic fracture. And if you get a hip fracture, which 70% of all hip fractures are in women, you will not return to pre-fall function, and 30% of the time we die due to complications. It is, I'm not kidding. This is why I get so like, can we please?
No, it's not. It's very serious. This is the
yes. So how do we build better bone? Well, nutrition, some of the things we talked about before, including adding enough protein in our diets to build bone. Bone is 50% protein. So we need enough calories. We need enough protein. We need to build lean muscle mass. Muscle is a communicator with bone and pulls on bone to tell it to be stronger. We need to develop a multi-directional jumping practice. So it's jumping up and down with impact, but better jumping from one leg to the other 20 to 50 times a day with impact.
Okay. But putting an exclamation point on this, from balance to strength to everything right now.
That's right. That's right. And so just a little differentiator. What's the difference between plyometrics, which I talk about all the time, and jumping? Plyometrics is explosive movements like box jumping, which scares a lot of people. That is meant to retrain your power. Jumping is not plyometrics. Jumping is meant to have impact, literally, to teach your bones to build more bones. So, and I have a whole class on this and talk about it every day on Instagram. So eat more protein, cut out all the risk factor things I talked about, including if you're smoking or vaping, it really is not cool for bones. It doesn't look cool. It's poisoning your bones. And then jumping and building muscle.
Great. And there are questions from women on of what if you already have osteopenia or osteoporosis?
If you have osteopenia, do all this. If you have osteoporosis, then you can still do all this. You should also then consider with your endocrinologist or your doctor whether or not your bone density is so low, you should consider a medication, either a anti-resorptive or there are newer categories which it would take another 6 hours to get into. But
Okay.
have the conversation if you're minus 2.5 or below. But what you cannot do is just hope it's going to get better. It's not going to get better. It's going to get worse unless you actively intervene.
Yeah. And again, giving women agency, which you said at the beginning of
Right.
this, that every
That's right.
single movement counts and
It
contributes to
does.
future you. So underscoring that.
Mhm.
I know we're going to be edging up on time here, and this is also a big question, but we know that the rise in popularity of GLP-1s is,
Mm.
I don't know how many women on the call are taking them, but can we just talk a little bit about, because it's not frequently talked about as much while they're advertised very broadly. Can we talk about if you are on GLP-1s, and how to think about bone health and strength?
So if you're on GLP-1s, again, I do not believe that they are a silver bullet, that they're the last thing you should do. It's just like MHT. You shouldn't just do it and think that's going to take care of all ills. Because when you lose weight without lifting weights in order to build muscle, you're going to lose a large percentage of the number on the scale in lean muscle mass. And that will just put you into a metabolic uh, vortex, because without enough muscle and more fat, fat communicates with bone and decreases bone density. Fat does not metabolize sugar in the way muscle does. We can be skinny, but still metabolically fat. And we know that that's a risk cancer. That's a risk factor for breast cancer and many other kinds of cancers. So if you're going to make a decision to use GLP-1s, and there's a lot of reasons to do that, including anti-inflammation and disease control, in addition to losing weight, then it can't be the end all be all. We need to eat appropriately. You're still not a garbage trash compactor. We must learn to lift weights. That is the sum total of my thoughts on, because I'm not opposed to them. I think they're
Yeah.
useful, just not
Yeah.
in isolation.
It's taking all of these tools together.
That's right.
Well, there are a couple of questions I want to get. I know we're kind of jumping. This is the end where we're trying to, squeeze some of the top questions in, but, back a little bit to the frozen shoulder question. Do you recommend surgery, is one, and then also let's start there. Yeah. If a
So
doctor's
you know what?
recommending surgery.
Frozen shoulder can go on and on and on. The literature says a great paper by Joe Hannafin, who's a mentor of mine at Hospital for Special Surgery, cites that it can go on for 2 years. And often what people are just so fed up, what happens is the actual inside capsule of the shoulder contracts, often with such dense scar tissue that it's just never going to move. That is the only reason, and as a last resort, to do surgery. Should never be offered to you if you've had a frozen shoulder for 6 weeks and you show up once at the doctor.
Okay.
So, yeah.
Okay. And can frozen shoulder impact pain elsewhere in terms of can it radiate, I suppose?
Shoulder pain does not radiate. Pain that
Okay.
moves is usually neck pain, cervical spine.
Okay. Okay. Well, I think a lot of this too is just finding the right doctor, right? Finding someone who can actually address and understands the impact of hormones, especially on joint pain, bones, and the like. You are incredible, but there was only one of you. Who should a woman see, and how do you recommend that they advocate with or find the right expert?
Well, you know what? The first thing I would do is educate yourself and just Google online musculoskeletal syndrome of menopause and my name, and the paper that we wrote will show up. We paid to have it open access so that you can download it for free, read it, share it with 5 girlfriends, print a copy for your doctor. And if your doctor is curious, they will read it. Now, I'm not guaranteeing that they're going to be curious. They may say, yeah, fine, I'm not reading that. But I don't want you to be discouraged, but there are not a lot of doctors who recognize menopause and fewer who can accurately talk about the musculoskeletal system. So it just, you have to really be your own advocate. If you want someone like me, of course, there's no one like me. However, Dr. Jocelyn Wittstein at Duke writes with me on a number of papers on this topic. So if you're around that part of the country, go see her. Or Dr. Nancy Yen Shipley, another orthopedic surgeon in the Northwest, also has a huge interest. Doesn't give us money resources, does it? But at least there's two more.
Yeah. And there are, especially if you're just looking for a menopause practitioner, we have, and Donna, my colleague, and Let's Talk Menopause CEO dropped, I believe, the tips for getting the menopause care you deserve in terms of various resources to find a menopause certified specialist in your area, which is just the start of it, right? Who might be able to make recommendations.
Yeah.
Well, I'd love to hear, we've covered so many things that a woman can and should do, but, where, I guess, trying to put a bow on this of, where, if there are top 2 or 3 things that you always just recommend every woman do, no matter where they are, no matter what they're experiencing, how, if women can get off this call outside of one, going to Unbreakable and pre-ordering the book. There's more of it here.
That now.
2, following Dr. Vonda Wright, which we will drop in the links here. But really, what do you recommend that actions that women can take, or the key takeaways for today?
Only 4 things. Only 4 things. Number 1, gather enough information to make your MHT decision. Either way, we just want you to make it out of facts, not fear. Number 2, if you have 30 minutes a day, go learn to lift weights and then learn to lift them heavy. Number 3, take a walk every day after your longest meal. That is going to help your whole body metabolism, clear your brain, decrease your stress. And then 4, of all the nutrition things, cut out added sugar and add some protein. It's not a lot. It's just a lifestyle. It's just 4 simple things. And after you master those, you can layer on.
Yeah. Well, thank you for this talk today. We are so grateful. There's so much to cover. And as my colleague said, there are way too many questions that we could answer today. It's clearly a topic that resonates. Again, would really encourage you to pre-order this book that is out in August, although you have several other books as well and offer incredible daily lessons and educational tips and recommendations on Instagram as well. So thank you so much for coming. Thank you to everyone for showing up today and learning what's going on with your body, how to advocate for yourself. We have just launched a survey on Slido. We would really love your feedback on today. We read literally every single comment, and it informs what we talk about next. We actually, speaking of, we are planning our upcoming July menopause talk is on brain health. Oh, there should be a QR code here. Perfect. It's on brain health and cognition in menopause, which is actually alongside joint pain, our most requested topic. So come to talk about executive functioning, focus, and brain fog, cognition. We are targeting July 31st with an expert that is soon to be announced. So please come join us then. Thank you all for coming today, and have a wonderful afternoon. We look forward to reading your feedback in the comments. And thank you again to Dr. Vonda Wright for an incredible session today.